Top Bed Talk. So how are you keeping the pain away? Joff, Mike, what did you hear in the general discussion?
The pain one was probably the most amount of interest from the audience. I think it's because it's a common problem, really, with our inpatients. The term I really enjoyed looking at and hearing more about was the optimal analgesia, that we shouldn't be targeting patients to be pain-free. I mean, obviously, if they are, that's great, but you should be achieving as little amount as pain that allows the patient to return to a reasonable amount of function, and therefore you can minimise the side effects. And I think that term of optimal analgesia is better than that target of going, right, we've got to, they're in any pain, we've got to give them more pain relief. And that was quite impressive. And as you can see that from the 3-dial infographic that you described. But yeah, it generated a lot of conversation and interest. Everyone has their different recipes for how they deal with pain in the perioperative period. And, there are lots of ways of doing it, and not everyone agreed. But I think generally there was this overwhelming agreement that we probably aren't doing enough a lot of the time, and that there really needs to be a true perioperative approach, that you really do the best you can preoperatively to give patients, load them on simple analgesics, to have a target of almost no opiates, not just opioid sparing, but no, we use too much opiates. They're not good. They have far-reaching effects outside of the inpatient stay. And there is lots more that can be done, and things such as lidocaine infusions and ketamine infusions, which are, in the places I've worked in the UK, are very rare, if at all, but there certainly seems to be a growing trend here in the US. Is that right, Julie? It seems to be quite a few units of the people here saying they use that almost routinely. So there's a lot that can be learnt from the cross-pond discussions. So it's been great.
And the opiate, because we've been having quite a guilt trip recently as people involved in major surgery, that perhaps we've been inadvertently drivers of some of the opiate addiction that comes up after major surgery. Was that discussed? Because looking at the slides and looking at the recipes and all the discussions, it seems to be very, very light on opiates, on morphine type of drugs, compared to what we were historically used to.
I think that's been a fairly major theme, not only of this particular session, but also the introductory talks. As just certainly in the United States, one of the major background contextual factors is this, if you like, epidemic of opioid use, which may in part be attributable to operative use, which is being continued into the post-operative and then domestic setting, and very much the emphasis of the POQI manuscript, which I think is very nicely illustrated in the second diagram, is avoidance of opiates, focusing on the whole perioperative journey, and then using a mixture, multimodal approach for the rest of your analgesia, so you're minimising the side effect profiles from a variety of drugs working together.
And all those recipes and all the proposals, there's a pain 1 and a pain 2, there's the initial bit and there's the journey to home, are all in those excellent papers that can be found online. Top Bed Talk. So there's 2 pain papers online, so if people are able to look at the slides, if they hover over it, they'll get a hyperlink to these consensus statements on perioperative pain management. And within there's a diagram which is really great, that is these sort of 3 speed dials, which start with optimized patient comfort, fastest recovery, then fewest side effects, and the big goal at the end of it says encourages post-operative dreams, i.e. drink, eat, mobilizing, and this new S that's been added, which is sleeping. So do we agree that's one of our key objectives, is to get people back to normal quickly?
Back to normal. I would love to say back to normal quickly. I don't know that I care so much about the speed, so long as their trajectory is appropriate and they're happy with the speed. But I would say most people want to get better and leave the hospital. Interestingly, when we start talking about hospital stays for procedures such as colorectal surgery, and traditionally across the country, we still have, I don't even need to say traditionally, we still have length of stay between 5 and 7 days for most segmental colectomies. Even laparoscopic goes only down to about 4. So when you talk to a patient who has no idea what that is, I'm very intimate with that literature, but you talk to a patient who doesn't have a clue what to expect. Oh, you're going to cut into me. Okay, what are you going to do? And you tell them you'll be in the hospital from 3 to 10 days. they're quite happy with the trajectory of leaving in 5 or 6 days.
Yeah.
Where if you tell them you'll have to stay in the hospital overnight, it's just one night, you just have to stay in the hospital overnight. And then the next morning, you and I will discuss what we're doing for you in the hospital and when we can stop doing that and you'll be ready to go home. You have 83-year-old women sitting on the side of their bed dressed at 6 a.m. rounds because they want to go home. They want to get back. They want to walk their dog and sleep in their own bed and have their own snacks. And so I have found that patients are very motivated for this to go much more quickly than most providers are even comfortable at this point, if given the choice. If they're given the education, you are able to do this and you can take care of yourself and you will recover better at home, most patients want to do that.
Top Bed Talk.